Thank you, Summer. Good morning and welcome to the Extracorporeal Hour. I'm Cedric Dufayet. I'm the head of nephrology and hemodialysis department at the University of California Veterinary Medical Center in San Diego. And I'm one of the co-hosts of those sessions, as most of you may know. I think Jethro is traveling, so he might connect but not be able to talk much today. So I'm gonna be left with most of the talk, or hopefully some of you will have some topics to bring up. If does anybody want to introduce? Is there like some new people around? If you want to introduce yourself, please turn on your camera. Tell us where you come from. What is your activity right now? It's always nice to see some new faces and learn to new people. So we can take a few minutes for introduction before we start to bring in some topics.
Hi, can you hear me?
Yeah, good morning.
I
Paul.
Hi, for me evening.
Yeah. I was thinking you're in Hong Kong, right?
Yeah, exactly. Yeah, I'm Zinat. I live in Hong Kong. We are starting our dialysis program soon, and I have like one or two questions, and I was wondering if I could ask them someone along this hour.
Sure. Yeah.
Okay, right now or
I don't know if
later?
anybody else wants to come to the mic right now, but if not, yeah, let's dive into it.
Okay, just wait a second or
Yeah, no, let's go.
okay, okay. Um, as I said, we're about to start our program, and we were very happy that our ACT machine is still working and everything. And then now the supplier said like the ACT only works for 6 months, so they didn't want to sell us anything before we say like, okay, we're actually starting. And now we said like, oh, we're good to go, and they said like, ah, tough luck, no ACT. Um, so I was trying to find a protocol for PTT for the coagulation when you do yeah for PTT, and I couldn't find a lot, and it says like you only have to check it every 6 hours, and I felt that is like really weird, and so I was wondering if anyone could help me with a protocol, what you would do for PTT to check your coags.
All right, yes. It's a bit, there's definitely some people that do not use the ACT machine anymore, either because they don't have one or the disposables are not available. Um, I know that Dr. Langston she was at AMC like years ago, was already using APTT to monitor her treatment. As far as the frequency, I mean, I would definitely do that more than every 6 hours. I mean, it's up to the patient, but usually 6 hours is more like a human recommendation. I feel like I'm monitoring my anticoagulation more like every 30 minutes to 45, maybe to an hour if really stable, but definitely more than every 6 hours.
Yeah,
Um,
I assume so.
yeah. From what I know and some discussions, I mean, usually the recommendation is that to run an APTT around like twice as high as a normal one on your machine, on your device. But I'm sure that there might be who is using APTT right now to monitor apparent anticoagulation, and would you have some recommendation for CNET? No one? Everybody's using ACT still?
Yeah, we're still using ACT as well. It's Jethro. Good to see you guys. I'm traveling, but hopefully I don't cut out. But yeah, to your point, Cedric, I mean 1.5 to 2 times baseline, and then just like ACT, because I've looked into it because there are some supply limitations these days for our ACT stuff. Um, I would probably treat it similarly to how we do the ACT, which is every time I make once I hit my target, kind of run my anticoagulation protocol. and feel stable maybe every half an hour. But if I make a big change or give a dose of heparin, if I'm using heparin, or I'm struggling because each patient is a little bit different in the single treatment and between treatments, I run it the same frequency as I would an ACT if I was going to use PT or APTT rather.
Okay. I have like reference that says like, okay, if you're there, you should like do this and this. So I hope that works. I hope they are going to have stock back in end of May, and maybe we're lucky and we don't have to do anything until then. But of course, we're like both waiting for our first extra dialysis to start. So yeah.
And I
So
think
I still hope.
one of the main caveat with APTT is not so much is the cost, basically, because like an ACT test is usually pretty cheap, so you can monitor frequently, and you don't hesitate to just like run another one if needed. Where like APTT can run like 20, $30 per test, which increases the cost
Yeah, here it's even more expensive.
the cost of the treatment pretty significantly. On another hand, if you're trying to like skimp on the amount you want to spend and you're not monitoring closely, that's where you might end up with some trouble for your treatment for sure. And monitoring ACT and APTT is only just one part of it. You also have to look at the color of the blood in your circuit and such, and have some visual cues as well that might trigger rechecking your anticoagulation during the treatment, even if the previous values was satisfactory, I would say.
Okay.
Does anybody else have insight on monitoring heparin anticoagulation with APTT? Look if anybody was in the chat.
I'll just say I tried to do it once, and very quickly appreciated my ACT.
Yeah.
Okay. And yeah, then just one other question. I did send you an email and you never emailed me back. So I don't know if you ever got it or not.
Yeah, I got
That's my
the
other
email.
question.
Just never had time to actually look into it enough.
Yeah,
I
okay.
mean, everything looks good from the outside, but I haven't had time to play with it so much.
Yeah, I just revamped it, so it's a lot more. And as I said, like I don't have any Excel sheet that I could like. So I did the same program for example, for fluid calculation and stuff like that, and it seems quite good.
Yeah.
But I don't have an Excel sheet for the dialysis calculation, so I don't have anything where I can see if the app actually did what I wanted it to do. And so yeah, if someone could help me to have just a look so that I don't kill anyone when I try to dialyze it, that would be absolutely lovely.
Sure.
Yeah.
Will do.
Okay. Okay, cool. Thank you.
Does anybody else have the case or a topic in particular they would like to discuss today? All right. So then I might actually ask some feedback and experience that you may have. I'm getting a new case today, and it's actually a case of magnesium toxicity. So the patient that I'm getting is an 8-year-old 10-kilogram dogs that ingested a large amount of laxative, I think 3 days ago, and developed an AKI. The creatinine went from 1.6 to 4.2, and his total magnesium initially rose to about 5 to 6 milligram per deciliter and is now 10 milligram per deciliter. So the patient is being transferred for ongoing management of the acute kidney injury, but also potentially extracorporeal removal of the and treatment of the hypermagnesemia. Has anybody had a similar case, and what is usually your management, either medical management, or has anybody done any extracorporeal therapies on a case of magnesium toxicity? No one has experience with that.
No, unfortunately not. Hopefully soon.
Okay.
Well, Cedric, what's your plan? Um, uh, uh, it might be similar to we've always fussed about, my gosh, what do we do with patients that have vitamin D intoxication?
Yeah.
And I would think that it's a little different than that because there shouldn't, well, maybe there is an ongoing intracellular store of this stuff, and it would
There
behave
is.
much like calcium.
Yeah, so it seems like most of the magnesium is actually intracellular, and the extracellular part is pretty small. It's also like 40% protein bound, but that means that there's a large amount that we can actually remove with dialysis. And I'm kind of expecting too that if we remove the the ionized magnesium, basically, we should be able to mobilize some of the intracellular pool during the treatment, but likely it's going to take a long, prolonged treatment rather than just like a short treatment. Um, it's it's uh, it's kind of interesting though. Like the one thing I was surprised with that case is that actually the magnesium continued to go up 24, 48 hours after ingestion. And so I don't know if it was still absorbed or if it was like some redistribution. And I don't know if anybody had some such cases and if you're surprised at that kind of pattern.
Do you know, is it stored in the fat like calcium, like a vitamin D intoxication would, or is it
Well, I think in
just a
vitamin
big
D toxicity,
distribution like any other toxin?
yeah, in vitamin D toxicity, it's more like the vitamin D that is stored in the fat more so than the
Yeah, yeah.
calcium, right? So it's just like more the pharmacodynamic that creates the hypercalcemia. I think the problem with that case is that the hypermagnesemia not only is causing some uh, cardiac repercussions with like a very similar to what you would have with hyperkalemia, actually. Um, Also causing some neurological signs and acute kidney injury, I would say. And now that the creatinine has gone up to 4.6, it seems like the only way that the magnesium can leave the patient is actually impaired right now, which might explain why we won't see any recovery. Um, from what I gathered from the referring hospital, it seems like the patient is very polyuric to the point where they actually had a hard time keeping up with fluids. I'm thinking he's trying to excrete this magnesium as much as possible. Um, but definitely my plan is to dialyze today. Um, we don't have any low or zero magnesium dialysate, but I mean the usual concentration in our dialysate is close to normal. So I will have a gradient enough, I think, for diffusion and removal. And I'm kind of interested to see how that behaves because I don't I haven't faced a case like that. There's a few case report in people where they use dialysis with success, but it was also kind of a different type of magnesium overdose. It was more like injectable magnesium and iatrogenic, more so than like ingestion of uh, acute ingestion of a large amount of laxative. Usually, oral magnesium can cause hypermagnesemia, but of lesser magnitude, I would say, in people. So I'm definitely going to go for IHD to try to add the most removal and the fastest removal possible. I'm kind of not expecting that dropping the magnesium would cause any big change in osmolality that I should worry about. It seems like the dog is not azotomic enough that dialysis disequilibrium should be much of a concern. But I'm definitely looking forward to looking into the kinetic of that magnesium removal. I'm kind of planning to um, try to get some magnesium clearance during the treatment. Also see like how much of that I'm going to run ionized magnesium and total magnesium on the patient pre and post treatment just to see the fractions are kind of different. Because I would expect that with that high of a total magnesium, the protein binding might actually be lesser than the proportion of protein binding might be lesser than usual, because maybe all the sites are already kind of like taken by, and so we might have like a higher free fraction, I would say.
But besides the azotemia, what are the other clinical manifestations?
So essentially, it was bradycardia with, I think, an absence of. Let me go back. I mean, a lot of the effects of the hypermagnesemia are on the neuromuscular junction. The dog was unable to ambulate first at presentation, and he actually improved on that front, even if the magnesemia increased over the course of hospitalization. And usually, for the cardiovascular effects, they are actually using calcium gluconate, very much like we would for an hyperkalemic case. He had some EKG changes, but I'm trying to
You know, the EKG
find.
changes might be similar to calcium, where you have an absence of P waves, but don't have the ST
It's
segment alterations that you get
yeah,
with
yeah.
hyperkalemia.
So it's prolongation of the PR interval, increased duration of QRS, and prolonged QT. So pretty much a delayed intraventricular conduction and increased height of the T wave. So it looks more like almost hyperkalemia actually. And again, like in the human literature, they're using calcium gluconate to antagonize those effects, which I found was kind of interesting because I would have expected magnesium to behave fairly much like calcium. So it sounds counterintuitive to use calcium, but it's what's been described in the literature so far.
I think this is a very vague memory for me, but I think the purpose of the calcium is to actually displace the magnesium from the receptor, not
Yes,
actually to
yeah,
like counteract
that
its effects.
that's what that's described. Yeah, but it's kind of like weird that you actually like replacing the magnesium by the calcium and expect like the effects would be different. But um, yeah, I haven't had a case like that. Like total magnesium of 10 mg per deciliter is kind of crazy, I think. And in the stratification in the human literature, I mean, usually they consider that the EKG changes appear like in an interval of 6 to 12 milligram per deciliter, and that above 12, you're definitely at risk for hypotension, respiratory depression, and narcosis. Um, with even like cardiac arrest when you're like nearing 15 milligram per deciliter. So uh, I think the way I'm seeing it, like it seems like the total magnesium on that patient has been stable now. I'm just afraid that actually like persistent hypermagnesemia will trigger more acute kidney injury, more tubular injury, and that at some point the renal recovery might be more unlikely. So I'm kind of willing to remove as much magnesium as I can and decrease obviously the cardiovascular and neuromuscular effects, but also the effect on the tubules, and hopefully see some renal recovery. I also don't know how much of the acute kidney injury is from just the hypermagnesemia itself or from a pre-renal component, because clearly the criticalist I talked to was saying that his urinary output was more than the fluids they were giving, and they were kind of chasing it, and the patient was still dehydrated. So maybe there's a component of fluid management that we can fix as well. And in the recommendation for management, also furosemide is mentioned a few times, but obviously with the dog already being polyuric and mildly dehydrated, I'm not considering that right now. So yeah, most of the human cases, if they're not treating with extra therapies, will rely on saline diuresis and furosemide to increase the excretion.
So do you know if the dog's arrhythmia resolved on the calcium? Because I'm just curious, like what's going to happen to the calcium levels when you're dialyzing them?
Uh, So I'm not sure because I haven't like finished to like review all the records. I'm actually not sure he got calcium gluconate when he was hospitalized. But it's definitely something also that is mentioned in some pediatric case report where like if you're removing too much calcium during your dialysis, you might actually increase the side effects of hypermagnesemia. So you have to be cautious that you're not removing too much calcium while you're removing the magnesium. So like you have to pick your dialysate wisely, I would say, and try to maintain like your calcemia while you're like reducing your hypermagnesemia.
A question about the Lasix for you, Cedric.
Yeah.
Just because I know he's polyuric, but I assume part of the reason for Lasix might just be by increasing sodium delivery to the distal tubule. You know, you're gonna promote more calcium excretion. So even though he's polyuric, it still might be beneficial to give the Lasix. You know, just from, I assume it's polyuria from AKI is, you know, obviously different mechanism, so it still might be worth inhibiting that transporter. I don't know. I haven't really looked into the reason for it, but my guess would be just by increasing sodium delivery further, you can promote more calciuresis.
I feel like that's
Yeah.
the opposite of what you would want, right? Because you want the calcium to remain.
Yeah, that's true.
Lasix will let you, like, you will urinate out more magnesium secondary.
I think it's more like increasing the flow, increasing the overall urine flow.
Yeah, but I think it'll be at expense of like
Calcium.
volume and calcium.
Yeah.
And if I have a chance to get a urine sample on that dog before we start dialysis, I'm definitely interested also into looking at the fractional excretion of magnesium and maybe actually the renal clearance of magnesium that we had on that patient to be able to compare to the clearance we'll get with the extracorporeal treatment. But my guess would be that with the creatinine now nearing 5, its capacity of magnesium excretion through the urine is fairly reduced, even if polyuric. But well, we'll see.
Yeah, I agree.
I suspect this dog. I suspect that this dog's already at a maximum urine production with that magnesium that high. The Lasix is going to change the transmembrane potential across the thick ascending limb. So it might, and if you're dialyzing the dog, you probably aren't going to lose a lot of calcium because the dialysate would likely keep the calcium constant.
Well,
But
I'm definitely looking at a dialysate with a calcium of 2.5 to try to stay like around like normal
maybe even
values.
3. Do you have one with 3.5?
I have to look into it, and that was actually one of the question I was adding and trying to look yesterday between CRRT because there's still the possibility I think to use the Prismax and try to maximize the clearance by using it more like in a PIRT mode with a lot of diffusion and convection at the same time. Basically, if we look at the Prismasol, the magnesium concentration through the range is anywhere between 1 and 1.5 milliequivalent. So which would make which like brings us like within normal range for a dog. So like anywhere between 1.2 and 2 milligram per deciliter, I think. So you still get like a decent negative balance if you're using that kind of dialysate. Looking more into the centrisol, we're going to be around 1 milliequivalent per liter of magnesium. So that should, I mean, that will definitely do it. And at the same time, making sure that we're not dropping the magnesium too much during the treatment, which would be detrimental, I guess. So kind of like a safety net to keep that 1 milliequivalent per liter of magnesium concentration. The other thing that I didn't see discussed, like if you're using like citrosate, for example, citrosate should be able to bind some magnesium just like it does bind some calcium. But we're back to the question of what is going to be the most beneficial, and should we even consider that, because we don't want to lose any calcium as much as possible. But anyway, it seems like it's going to be a fun treatment, and I might be able to come back in 2 weeks with more data, and see how the magnesium removal work during the dialysis session. The other question I had, and I don't know if anybody has any input on that, is just like, what should I expect in terms of treatment schedule? Because my feeling is like, even let's say I'm dropping the plasma magnesium concentration within normal range tonight, with magnesium being mainly intracellular, I'm kind of expecting having a rebound and having to treat again tomorrow or 48 hours from now. So I don't know like how many treatments it's going to take me to actually correct the hypermagnesemia and the overall magnesium burden. And then what is going to happen with the acute kidney injury as well? Like, is a kidney injury is going to improve right away once we correct the magnesium, or will there be enough damage that we're going to have the more classic course of like 3 weeks to 3 months of recovery?
I think the dog's going to tell you the schedule.
No, for sure. But I was just like trying to discuss with the criticalist yesterday, like how many treatments we should prepare the owners for. I mean, my take on that was just like, well, I'm gonna plan for at least like 3, 4 treatments over a week, keeping that the hypermagnesemia is my main concern right now. And then depending on the azotemia and the acute kidney injury, we'll see if we need to prolong that. But I would expect that with 3 to 4 treatments, should
Yeah,
be able to remove most of the magnesium from that dog.
I would suspect that a lot of it's going to come out in the stool too, if the dog's not so dehydrated. So if it gets diarrhea, a lot of the ingested magnesium is likely to
Yeah.
be excreted. So, I would think that probably 2 or 3 treatments would probably manage the magnesium, and then just have to deal with the AKI.
Do you know which laxative it was, Cedric?
So she told me Dulcolax, which I was kind of surprised, because in my mind it was not the magnesium based, it was like bisacodyl. However, it sounds like Dulcolax is actually a generic name now for like a whole array of different laxatives, and some of them do have magnesium. And it's like, I think it's a combination of magnesium citrate and magnesium sulfate. But I would have to check that, because the problem is they have like different ones, and I don't have the specifics right now. Looks like they have some soft chews with magnesium hydroxide actually, but some other magnesium citrate. So that's something I will need to dig into as well. Do you think that will make a difference now?
Oh, I have no idea.
Yeah.
I was just wondering, just based on the salt or whatever it's with, I don't know if that changes the absorption and things like that. So I was just curious at trying to look into what it was. I think just from a quick Google search, magnesium hydroxide seems like it dissociates and the magnesium gets absorbed in the small intestine, where some of the
Yeah.
other ones, the magnesium is less absorbed. So
Yeah, I'm definitely, again, I think it's going to be interesting to look at how much ionized magnesium compared to total magnesium we have. And now it varies over time. But yeah, it's not, I don't feel like it's a common toxicity. I mean, I don't know if those of you who work ER, ICU have had a lot of magnesium overdose like this. I mean, the literature is pretty pretty scarce on the topic. And yeah, I think it's the first that I have heard of.
I
It's
never
not
had
something I've
one.
come across.
Sorry?
Oh, sorry. I was just saying it's not anything I've come across in the ER too often. The other thing too, it's a laxative. So I guess like I assume this dog's having pretty wicked diarrhea. So I don't know if the GI absorption is really that much of an issue anymore, I guess, but I don't know.
No, I wouldn't expect that. I mean, it's like again, he got into it 3 days ago, which is I was kind of bummed when I was on the phone that they would call me after 3 days, and because the case was going sideways. I feel like we could have intervened sooner and maybe prevented some of the acute kidney injury. Again, I don't know how much of the kidney injury is from like dehydration, um, maybe, but it seems like the blood pressure was pretty stable on the patient. There was like no clinical hypotension, but with the cardiovascular effect, you would expect like some decreased cardiac output as well. I mean, hopefully most of the acute kidney injury is perirenal and we might have a better recovery from that part. But just like with hypercalcemia, I mean, with that magnitude of hypermagnesemia, I would still expect some acute tubular injury. I don't know what you think, Dr. Cargill, but I mean, having a magnesium that high cannot be healthy for the tubules, I guess.
Yeah, I would suspect the AKI is multifactorial.
Yeah, no, definitely.
Yeah.
So also why I'm kind of feeling that if we see some recovery, it might be a bimodal recovery with like some of a perirenal component that would correct like pretty readily, and then like the acute tubular necrosis or nephrosis would take longer to recover. But so that's what I got on that case. I mean, kind of exciting having something new to play with.
Well, we look forward to hearing the results of that.
Yeah, it's like a hell of a teaser, right? I hope I'm gonna do a good job. I'm gonna look bad in 2 weeks.
Well, one of the real interesting features of extracorporeal therapy is every day is a new challenge and new excitement, and it never gets boring.
So on the topic of these kind of like electrolyte disorders, like has anybody treated a patient for hypercalcemia and vitamin D toxicity? And what is your approach on those? Because I know that we've talked about removal of vitamin D with hemoperfusion, for example. My feeling is that when they present, they're usually already hypercalcemic and the ingestion has been like uh, a long time ago. And we may not have the opportunity to remove much of the vitamin D burden. Like we might decrease the concentration in the plasma, but with all the vitamin D that has been stored in the fat and that will be released progressively over weeks to months, I don't think we can make much of a dent there. And so if we treat with the extracorporeal therapies, might be more like with dialysis to maybe decrease the hypercalcemia, but similarly then we likely have to repeat treatments and treatments and treatments because the hypercalcemia will keep coming back because the vitamin D is still released from the fat stores. I know that you've treated a lot of patients during uh, the pet food contamination event, like about like what 10 years back, Dr. Cargill. What was your experience with those? Like, how long did you have to treat them before they would actually improve?
Well, it looks like Carolyn's got some insights on this as well. So I've given this a lot of consideration over the years, and actually we didn't treat a lot of those during the pet food contamination one, but they pop up every once in a while, and the most recent thoughts that I've had on this, and I discussed it a lot with Ed Sullivan up in Washington. You can deal with the calcium pretty readily with dialysis, but that doesn't get rid of the vitamin D. And so I think plasma exchange is where we when we talked about it, we thought would be a good idea. You could do plasma exchange on these, maybe give them interlipid and try to get some of the vitamin D out of the fat into the lipid in the bloodstream that you could remove with plasma exchange. And then using regional citrate, you could bind the calcium and probably not have to give a lot of calcium replacement. That would be a little tricky. And so that was a strategy that I thought that I would use with the next vitamin D intoxication that I saw. And you'd probably have to, I don't know how much transference you'd get into the interlipid, but that to me seemed like the most rational and novel way to try to go after these. But boy, I'd sure be anxious to hear anybody else's thoughts, because that's been one where I don't, yeah, we can manage the calcium, but we don't manage the vitamin D
Yeah, that was
intoxication.
my feeling too. Like we could like improve the azotemia, we could manage the calcium, but we would have to treat as long as the vitamin D is still around and having effects. The way I see it too is like I feel like most of the time when we talk about that vitamin D toxicity, we talk about like toxicities that happened like a few days back, if not a few weeks back, when we actually diagnosed with the hypercalcemia. I know that Matt in Oregon actually had the occasion to get one that the dog had ingested like 6 to 8 hours before. And I think that might be the right window to consider hemoperfusion, where actually, like as the dog is absorbing in it before it's redistributed in the fat, we've got a window of opportunity to remove as much as possible. Um, what's your experience in Tufts, Caroline? I know you've had a few of those.
So in the last, I don't know, year and a half, we treated two vitamin D toxicities. The first dog was a 4-year-old Bernese Mountain Dog, and she came to us 3 days after ingestion with an ionized calcium of 1.8. We opted to try hemoperfusion on him, and we did we did one session of hemoperfusion on him. His ionized calcium coming off the machine was 1.2. Um, the next morning, his ionized calcium was back up to 1.6. We did another therapy, dropped his ionized calcium back down to 1.2. It rebounded back to 1.4, but never went above that. Um, and he was otherwise asymptomatic and doing well with medical management, so he was sent home. Confounding the issue was this 4 months later, this dog was diagnosed with osteosarcoma and euthanized. So the question was his persistent hypercalcemia due to the undiagnosed osteo? The second dog we treated was last year. And again, this dog had been medically managed at the RDVM for 2 days, came in with an ionized calcium of two something. We opted to do IHD and hemoperfusion on him. We did two therapies on him. We did two successive treatments on him 2 days in a row. He was doing very well, was eating and drinking. Um, And we were going into a holiday weekend where we were going to hit a Monday holiday. And he really wasn't, we weren't doing anything for him in the hospital. He really was doing very well. Um, so we had planned on repeating his treatment on the Tuesday because we had done a treatment on Thursday. We planned to repeat the treatment on Tuesday. Um, we sent him home with his dialysis catheter, and this woman fed her dogs raw food. We were very adamant with her and were vigorous in telling her that she could not feed this particular dog raw food. Um, and unfortunately, she said he looked really, really sad on Saturday when the other dogs got raw food, so she gave him a raw food meal. Sunday, he presented to our ER in septic shock with a really bad vegetative lesion and endocarditis. So we weren't able to follow up on his treatment either. He was in the hospital for almost a month trying to treat the endocarditis. We were able to manage his hypercalcemia medically, but we weren't able to really either of those two dogs. The therapy was muddied, but it seemed like, the IHD in conjunction with the HP seemed to be controlling things. Like the 2 sessions that he had, his rebound ionized calcium after the second treatment, I think he was at about 1.6 and he was kind of staying there. And so we were planning on doing a third treatment on him and then hoping to stop after that. But we never got to the third treatment because of the endocarditis.
This
I,
may,
I have a,
sorry.
I was going to make one other comment. So circulating vitamin D is going to be bound to vitamin D binding protein. So that's going to be a big molecule that you really won't be able to dialyze out. Dialysis would surely help manage the hypercalcemia. The other thought I had on the plasma exchange theory, where we could remove the vitamin D and the vitamin D binding protein with plasma exchange, and maybe accelerate that with using interlipid. The carbon hemoperfusion cartridges actually remove interlipid pretty readily, and so if you didn't have the ability to do plasma exchange, it might be possible that you could give interlipid, and if the vitamin D mobilizes out of the fat into the lipid, that might be a mechanism of clearing it from the body. And the other advantage of the carbon with the lipid is that the carbon removes the lipid, so you can periodically redose the lipid, where you really have a limit if you're just using lipid by itself without some way of removing it. So that might be another strategy, but haven't had it all tried that yet.
To me, the IHD and hemoperfusion kind of makes sense, because then you can use the same platform, and you're assuming that the dialysis will provide the calcium removal, and the hemoperfusion will provide the vitamin D removal. And even if the vitamin D is bound to the vitamin D binding protein, is exactly the same situation where, like, we're still removing ibuprofen even if it's 95% protein bound with hemoperfusion. Erica brought up that paper that I'm sharing on my screen about 2 cases of severe vitamin D intoxication treated with TPE and hemodialysis. And that was kind of a reasoning too, is like, we're going to remove the vitamin D with the vitamin D binding protein with the plasma exchange, but then we want to have some high cutoff dialysis to treat the hypercalcemia. The takeaway I have from that paper, though, is that if you look, like, during follow-up, patients achieved almost normal total plasma calcium and vitamin D concentration after 355 and 109 days.
Yeah.
Meaning that even if we're able to very effectively remove vitamin D from the plasma, the volume of distribution is so huge, and the fat stores of vitamin D are going to release like over weeks and months, that we probably have to consider that we will have to treat that long before we actually exhausted that pool of vitamin D and hope for like correction of the hypercalcemia. And
That's where I would hope that maybe the lipid would have some capacity to help mobilize the vitamin D in the fat stores. I don't know that it does, but that would be that'd be an interesting project to do, to see if it could actually translocate that vitamin D and facilitate getting it out of the fat. Where if you're doing plasma, I don't know what the turnover rate for vitamin D binding protein is, but you're probably going to need to, if you're doing plasma exchange and you're removing all that vitamin D binding protein, then you're going to have to wait for that to replenish before you can get it back into the vasculature.
And then the question is also like, what are the good candidates for that? Because the last vitamin D toxicity that I had, um, the dog had been hypercalcemic for a while, but his creatinine was sitting in like the 2.5s. I don't remember the ionized calcium on top of my head. And the vitamin D levels that we sent to MSU were like through the roof. I think the vitamin D was more than 2000. And that was like at least 6 to 8 weeks after the reported ingestion. And actually with furosemide and some steroids, we're able to control the calcium enough and the renal values improve without having to go to extracorporeal therapies. So I guess like except like for very severe intoxication with an hypercalcemia that would be really life-threatening, I'm not sure like extracorporeal therapies will be beneficial in milder cases
Yeah,
because we just can't remove everything.
I guess what I was going to ask is like how many of you are recommending this as I guess a first line treatment? Because treating many of these over the years, like I don't offer extracorporeal therapy to a patient that just came in and just ate it. Like we decontaminate them. And I
Yeah.
feel like as long as you can manage their calcium, they don't tend to develop renal dysfunction. Because like the vitamin D, my understanding is not specifically toxic to
No.
kidneys. It's just the hypercalcemia. So as long as you get them early and prevent that, and honestly, like I usually just give them bisphosphonates and it's fine. I've not used it. We treated a cat recently that unfortunately got euthanized, but she unfortunately did eat vitamin D, came in with a normal calcium, normal phosphorus, but was azotemic. So that was interesting. So we were treating her specifically because of the AKI. Um, but yeah, it's not been something I guess, recommended. It's interesting to hear.
Well, it's not something I've been recommending either because with all the limitation that I mentioned, like usually we see them way after the fact, and I feel like we won't be able to remove the vitamin D effectively, and usually the hypercalcemia we can control with medical management. But I still think that if we can intervene like right after ingestion and maybe with hemoperfusion, we might be able again to remove, like really decontaminate the patient, like um, everything that is absorbed before it's redistributed in the fat, we might be able to catch it at that point and reduce the overall burden and maybe prevent the hypercalcemia or actually make the persistence of a vitamin D in the patient shorter in time.
Yeah, I agree
Does
with you, Cedric.
does hemoperfusion remove the
It
vitamin
does.
D? It does.
From our experience, we submitted an abstract, and these are the typical frustrating cases where, like we discussed, the plasma concentration is probably not representative, right? So we wish we had a better way to really prove how much we are doing and how much we're doing compared to how much is in the body. But we had about a 36% decrease in vitamin D level. But again, I kind of agree with Cedric that how I see these cases is if you have the luxury of seeing them early enough, I would not wait for the hypercalcemia to happen, like I would not wait for my NSAID toxicity for the creatinine to increase, right? Because once the hypercalcemia is here, you know that everything is in your tissue, and it's going to be really hard to get rid of them. So I would argue that we know we can decrease with hemoperfusion. And so if we are in a good timeline, I would really encourage, of course, always weighting benefit versus risk, but I would encourage to try to get rid of as much as possible before we are sort of stuck in this. We are hypercalcemic and now it's in the tissue and we don't really know how much we're going to remove with our extracorporeal therapies.
Yeah, I really thought like unless we intervene like very early and we have a chance to kind of remove it with the first pass, after that, I think the half-life is like 15 days.
Mm-hmm.
So like there's no way we're going to be efficient. with extracorporeal therapies, unless like we repeat treatment and maybe treat like 3 times a week for like 6 to 9 months. But do we really need to do that is a question. We might be able to manage it medically better than that.
Yeah, I guess like my question would be like if the dog, walked in the door and you treated them like day one, how do you really know that you cleared enough of that vitamin D to feel safe to then not do anything? I feel like you're still gonna have to follow up that dog,
For
see
sure.
if they
I think we
become
don't know.
hypercalcemic and stuff. So and
Yeah.
I don't mean to recommend waiting till they're azetemic to do something about it. I guess I just meant like if you can prevent or catch the hypercalcemia early enough, maybe you don't need to go down this road. I don't know.
Yeah. No, I think that's the whole question. It's just like knowing that we have a device that can effectively bind vitamin D. Is it something that we would consider like early after ingestion to try to decontaminate the patient and reduce the morbidity of that toxicity? And how efficient are we going to be to do that? I guess like until we actually treat some patient and get some data, it's going to be difficult to just guess about it. But I mean, unless we get a case where like we are treating in the, I don't know, 3 to 9 hour window, or even 12-hour window, with a prolonged hemoperfusion treatment, and we see that the dog did not develop hypercalcemia after that, that would be awesome. But I doubt that that would work that well. But maybe it would like decrease the magnitude of the hypercalcemia afterwards. I don't know.
Yeah, you probably ought to give them a lot of laxative too to get rid of the test.
And then we're back to the magnesium toxicity. That's what you mean? Like for full circle. I actually don't have a good knowledge of the vitamin D pharmacokinetics and what would be the Tmax. And again, if we have some data on that, it probably would be for like normal doses anyway, which may not apply to like overdose. But at least that would give an idea on how long we may have to treat. Like if the absorption is pretty slow, we may have to do a very prolonged treatment. Whereas if the absorption is pretty fast and the Tmax is within a few hours, um, if we intervene early, we may not have to treat as long. But again, that's all theoretical, and unless we actually have some data, it's difficult to recommend that treatment, I think.
Yeah, I don't know what the Tmax is, but I know just from a like monitoring perspective, like we watch out for like 96 hours to see if they're going to become hypercalcemic before we say
Yeah.
we're out of the woods. So it feels like it's probably long.
Yeah. All right. Any closing comment? All right, so we're almost
We
at
had
the end of the hour. Yeah.
we did have a case of PLN that we were treating recently that had a pretty significant catheter associated complication.
Oh.
I can certainly talk about, but it's probably more than 4 minutes worth. So maybe I can save it for next time potentially.
Yeah, that would be awesome actually. If you can like prepare a little something for like in 2 weeks. What kind of complication did you get just as a teaser?
It basically a thrombotic complication. It developed a pretty extensive thrombus on its catheter almost like instantly, like after the first treatment. Had a massive thrombus kind of at the tip. It was kind of right at the atrial caudal caval junction, and the thrombus was causing like a Budd-Chiari-like syndrome with right congestive heart failure, significant hepatic venous distension, ascites. The thrombus extended all the way up to the visible portion on the jugular on ultrasound. Like you can see the thrombus kind of the entire extent of the catheter. And was talking to IR about interventional options to kind of assess it. And, ultimately what we settled on was trying to just back the catheter out a little bit to kind of provide some flows because the dog was hyperkalemic and still needing extracorporeal treatment and to infuse some TPA as we kind of backed it out to try to dissolve it since it was such an acute thrombus. The dog also was pretty thrombocytopenic as well. And I think it was just massively consuming, platelets and was kind of in a state of DIC almost. It developed some pulmonary hemorrhage, kind of potentially before the TPA, but potentially also worsened by the TPA.
Don't spoil the whole story.
Yeah, I can get some images though, which will be
that would be cool. Because I think definitely that
think about how other people might have managed it, or but it was pretty significantly, despite being on Plavix and enoxaparin, kind of developed this thrombus almost instantly.
Well, yeah, I think that would be an awesome case to discuss like 2 weeks from now, because you probably have some like super nice imaging on that. It's probably a pretty graphic case. And then we can probably just like transition to thrombosis prevention with dialysis catheter in our patients, because I've never been like super convinced with just clopidogrel, and I don't know who's using rivaroxaban or apixaban as a routine for prevention, but I think that could be a nice discussion topic for 2 weeks from now. All right. Well, thanks everybody for your attendance and comments and inputs. It's always like a very nice to have discussion and have ideas go back and forth. Yeah. So let's plan for that now. If you can put a few slides with some images, I think that would be great discussion.
Yeah, that sounds good.
All right. Have a good Friday, and we'll see you in 2 weeks.